Hey guys, I am Dr. Nyasiabonnett and I am the Nurse Doc Tutor. Welcome to my channel. On this channel, guess what? My job is to help you pass nursing school. So if you are struggling with nursing school, this channel is for you. And I also offer private tutoring sessions to nursing students. So let's get into today's lesson. So today's lesson will be on Next Gen NCLEX practice questions. We're going to go through three practice questions, and this will give you a feel on how the new NCLEX style will be and how some of your test questions could be as well. So let's get into it. So the first question. So you see that we're greeted with this long case study. We have lab values, we have nurses' notes, we have vital signs. So let's dig into all this information. So it says at 1,300 hours, a 86-year-old client with altered mental status who is accompanied by their child is admitted to the med surgical unit, and the nurse is performing an assessment. The client has an IV solution of 1,000 ml bag of normal saline hung at 12 o'clock in the ED that is infusing at 100 ml per hour. 1 hour after the admission, the client child calls the nurse and reports that the client has a pounding headache and is having trouble breathing and seems scared. So that is the scenario of what happened. So before we move on to the nurse's note and the other things, we want to get the wheels in our head spinning and be like, well, what could be going on with this patient? What is some pertinent information that we want to grab from that? And what I would grab from that is her age. So 86, okay, I know that this patient is elderly, so I know that certain things happen in the elderly population. All right, so let's go on to our nurse's note. It says at 1,300, the client is weak and reports they have not been able to eat or drink in the past 3 days because of anorexia. Her skin is very dry. Her mucosal membrane is dry and she is sleepy. It says that the child reports that the client has a history of heart failure, hypertension, and hyperlipidemia. The client's breath sound is clear bilaterally, and the medications include lisinopril, Coreg, and digoxin. At 1,400, the client is dyspneic. So the client is short of breath and complaining of chest tightness, coughing, and is pale, has neck vein distension. The client's breath sounds are wheezing and congestion bilaterally, and there is 500 ml remaining in the IV bag. All right, so before we move on to their lab values and their vital signs, let's look at the nurse's note. So we can see that the patient, okay, is weak. I think that's pertinent information. The patient is weak. The patient hasn't been eating or drinking, and the patient is dry. Their mucosal membranes is dry. And what is also very important, the patient has heart failure and hypertension. So we see that at 1,300, our patient kind of was at their baseline of how they were at home. And then at 2 o'clock, 1,400, some things started to change in that patient. That patient's breath sounds weren't clear anymore because they were clear before. At 1 o'clock, they were clear. So you want to start to think, how could that patient go from clear breath sounds to now we're hearing wheezing and now we can hear congestion? All right. So, and at 12 o'clock, we started a 1,000 ml bag, and now it's 1,400, and now the patient only has 500 remaining in the bag when the rate was only supposed to be 100 ml per hour. So we got the wheels in our head turning like, wait, it seems like this patient could have got too much fluid, a medication error. Why is there only 500 left in the bag when it was only supposed to be going at 100? So begin to start thinking of little scenarios in your head, like something went wrong after these fluids were started. The patient started to decline. Something went wrong. So let's look at our lab values. We have your BUN, and it says that is high. So one good thing about these questions is they tell you if your lab values are high or if they're low, and they give you the normal ranges. But it's not good enough to know the values, if it's high or if it's low, and you don't know what the test is actually for. So we need to know the reasoning for the test and be able to interpret what these lab values actually mean. So her BUN level was high, her creatinine level was high, her digoxin level was high, her sodium level was high, and her potassium level was high. So her vitals at 1 o'clock, she just had a temperature of 100.2, and then she had an apical heart rate of 72. Blood pressure was 100/68, respiration was 24, and her oxygen level was 90% on room air. Now at 1400, her temperature didn't change, but her heart rate went up to 110, and her blood pressure went up to 152/98, and her respirations went up to 28, and her oxygen went down to 89. So we now have so much information that we can start putting it together, like, okay, what happened with this patient? Her blood pressure went up, her heart rate went up. So now in my head, I'm already thinking that, hey, this patient is in fluid overload. This patient, kidney levels, her BUN and creatinine are high. So this patient is holding on and retaining fluid, and she has a history of heart failure. So that plays a part in to how much fluid she can get as well. So those are things you want to put it all together. All right, so now let's move on to the question. It says for each assessment finding below, click to specify if the finding is most likely consistent with dehydration, circulatory overload, or digoxin. All right, so let's start with anorexia. So with anorexia, will we say that have anything to do with dehydration, circulatory overload, or digoxin toxicity? So dehydration and circulatory overload, we know for sure that has nothing to do with anything. So we're going to go with digoxin toxicity. Let's say we don't even know what are the signs and symptoms of digoxin toxicity. We know that too much fluid or not enough fluid is not going to cause anorexia, right? All right, so dry mucosal membranes. All right, so we know that with circulatory overload, we're going to be wet, right? Because we're overload of fluid. Digoxin toxicity, let's say we still don't know. But we know that when we are dehydrated, guess what? We're thirsty. We're dry. So dry mucosal membranes, it's safe to say that's with dehydration. So with our BUN creatinine levels, let's say you don't know anything about these levels. We just know that they go with the kidney. So let's look at the lab values. So we see that the BUN and creatinine is high. And these are our lab values for our kidneys. So let's take a physiology break to discuss the BUN and the creatinine level in our kidneys. So the kidney's job is to filter out our hydrogen ions, which are an acid, our urea, which is the waste product of ammonia, and creatinine, which is a waste product of muscle. When there is not enough fluid to filter out creatinine and urea, these waste products will build up in the body. So back to the case study. Do we see why these levels are elevated? These levels are elevated because the patient is dehydrated. The patient is dehydrated, so the body is saying, hey, I'm not letting go any fluid. I'm going to hold on to all the fluid that I need because this patient is dehydrated. So while it's holding on to the little bit of fluid it has, it's not being able to push out your urea and your creatine. And also your potassium is not being able to push out those things. So guess what? You're going to have a buildup of that in your body because guess what? The kidneys do not have enough fluid to do the filtration that it needs. So we kind of answered two questions at once. So when a patient is dehydrated, the BUN levels will increase and the potassium level will increase. Does that make sense? So that's why I say it's so important that we hold on to our anatomy and our physiology, because if we didn't know how the kidneys work, if we didn't know what creatine was, if we didn't know how potassium was excreted, how urea was excreted, we would not understand why these levels are elevated. So our digoxin, we know that the digoxin level is high because guess what? It told us that it was high. So we know we're going to be dealing with digoxin toxicity. So elevation in blood pressure and heart rate. We know that fluid, guess what? Fluid increases your blood pressure. And when you're in fluid overload, your heart rate starts to increase as well to try to help maneuver all that fluid that you have going on. So circulatory overload. Wheezing and congestion in your lungs. Now that patient has a history of heart failure. It didn't say right or left, but we know that fluid can then get inside your lung and build up inside your lungs that can cause what? Wheezing and congestion. So we know that this patient already was at a risk of fluid overload just by having heart failure. So you want to make sure that you're always looking at the history of your patient. You're always looking at your patient age. You're always listening to your patient and listening to their family member. And neck distension. So we know that neck distension is a symptom and a sign of circulatory overload. All right, you guys. So that was the first problem. So this one just shows you when you have a case study, you're able to put everything together. So even though it only asks this question right here, you know, put these in categories, you see how we were able to make this be 11 minutes, how there was so much information into this case study. So case studies put everything all together. So let's work on the next one. It says that a 68-year-old client is complaining of chest pain, is being admitted to the med surgical nursing unit for acute coronary syndrome. The cardiologist prescribes a continuous IV heparin infusion per protocol. The client weighs 165 pounds, which is 74.8 kilograms, and the baseline PTT is 32 seconds. A bolus is administered as prescribed, and the continuous infusion is initiated based on the protocol noted in the MAR. So the protocol in the MAR is what it is. We don't really have to read that right now, but we know that this is the protocol, and each hospital protocol is different. So you always want to make sure, and there's different types of protocol. So it's not important to remember these numbers. Why? Because your protocol changes. So we can read the first part of it. It said a baseline PTT every 6 hours or 12 hours after the start of the continuous infusion based on the protocol, and the patient is going to be started at 25,000 units in some D5W. All right, so let's go to the next part of the case study. It says that the next day, the oncoming nurse is assigned to monitor the client, assesses the client, and checks their lab values. It says that the client states, I feel okay. I had a hard time sleeping since I've been in the hospital. My chest is better. I've had a nosebleed this morning, but it stopped. I'm ready for breakfast. It should be here soon, the nurse said. It says the most recent PTT from 1 hour was an hour ago was 92 seconds. The heparin infusion is running at 13.5 mLs. All right, so that's the scenario. It says select the priority needs that are of immediate concern. All right, so what is of immediate concern that the patient is going through? So we go back to the case study to find out what's important. So the patient said that their chest pain feels better. So guess what? We're not worried about chest pain right now. I know you wanted to choose chest pain as immediate concern, but we're not going to choose chest pain. Why? Because this patient says my chest pain is better. All right, appetite. Okay, that's no concern. The patient says they are ready to eat, so we're not concerned about that. But that nosebleed, are we concerned about a nosebleed? Even though it stopped, yes, we are concerned about a nosebleed. Why? Because the patient is on heparin, which is an anticoagulant. So if it's thinning the blood out too much, it can cause bleeding. The biggest side effect of heparin is bleeding. So we want to be monitoring that patient for bleeding everywhere, whether it's from their nose, whether it's for their rectum, anywhere, whether it's in their urine. We want to be monitoring that patient for any type of bleeding. So it goes to show you, so let's say, so that patient is bleeding. So that shows us that, guess what? 9 times out of 10, their PTT is too high. It's too high. But let's don't guess. Let's don't jump the gun. Let's actually go to the question. So it says that the PTT was 92 seconds. We look at the 92 seconds and we go back to our MAR. It says a PTT above 90 seconds, they will not get any bolus, and we need to stop the infusion. So what does our PTT mean? Our PTT literally just means that's how long it takes for the blood to clot, right? So that PTT of 92 seconds, that is too long. It's thinning out our blood, and it's taking our blood too long to clot. So we're going to stop the infusion, right? So our PTT results are so important. All right. How about our heparin infusion? Yes, the heparin infusion needs to be stopped. So the heparin infusion is also for immediate concern. Difficulty sleeping? No, I'm sorry. That's not a concern right now. A lot of patients can't sleep in the hospital, and we can try to do different things to help them sleep, but that's not immediate concern. So our immediate concern is around this heparin infusion, around this patient having this nosebleed and their PTT being too high. And if you look at the MAR, you see that the goal PTT that they want this patient to be is between 46 to 70 seconds. So that patient was at 92 seconds. That patient was way out of the goal range that they wanted that patient to be in. I know that was a lot, but this is how you critically think. You see how I was able to start to think that the PTT was high just by that patient having a nosebleed. So that's how I want you guys to start thinking. I want you guys to be able to start critically thinking, putting your pieces together. So let's try one more question. I'm sorry, let me highlight it on here. So we're going to worry about our nosebleeds, PTT, and our heparin. All right, so let's try the next question. So the next question says, a 58-year-old client is recovering from L4 to L5 spinal fusion, completed 3 hours ago. The client is on a med-surgical nursing unit and is prescribed hydromorphone via PCA 0.2 mgs every 10 minutes with a 4 milligram lockout dose in 4 hours. The nurse is preparing a plan of care for the clients. So the question said, for each body system below, click to specify the potential intervention that will be appropriate for the initial plan of care to monitor or prevent adverse effects of hydromorphone. Each body system may support more than one potential nursing intervention. All right, so renal. So renal, this is our kidney area. So potential nursing interventions. So this requires us to know about hydromorphone, which is Dilaudid. This requires us to know about that medication, right? That is a pain medication, and that is an opioid, right? All right, so with the renal, what are you want to do? You want to assess your renal function? Yes. And you want to monitor your I's and O? Yes. But do we want to maintain fluid restriction? No. So in this question, we're going to assess your renal function. Why? Because pain medications can cause urinary retention. And we also want to think about it as this, that patient just got back from surgery. So it's never wrong to always assess your renal function and monitor your I's and O, right? But hydromorphone can cause urinary retention. All right, so with respiratory, we want to assess the respiratory rate frequently? Yes, because opioids can cause respiratory depression, right? All right, do you want to ensure that naloxone, which is Narcan, is available? Yes, because we need that reversal agent at bedside if something would go wrong with that patient. Will we place the PCA on hold if the respiratory rate is less than 18? No. The respiratory rate would have to be lower than 12. All right? For it to be considered respiratory depression. All right, in your cardiovascular system, do you want to encourage brisk walking? Do you want to instruct the client to change position slowly, or do you want to assess the blood pressure and heart rate frequently? All right, so what about walking that a patient needs to do when they're on a PCA pump, when they're getting pain medicine? That has nothing to do with anything. All right, but do you want to instruct the client to change position slowly? Yes, because guess what? Hydromorphine can decrease blood pressure, right? So then that's why we would assess the blood pressure and the heart rate frequently, that we can have decreased blood pressure and decreased heart rate due to this medication. So that's why it's going to be good to frequently check that patient's vital while they're on that continuous pain medication, right? All right, GI. Are we going to administer methotrexate? Well, you can say, I don't even know what methotrexate is, so I'm not going to administer that, because what does that medication have to do with hydromorphine? All right, so will we administer aldoxatron as indicated? Yes, because what we know that aldoxatron, which is Zofran, that helps with nausea, and some patients experience nausea as a side effect of hydromorphine. Would you ensure adequate intakes of fluid and fiber? Yes, because why? Opioids can cause constipation. So we want to make sure that your patient is being well hydrated, and we can increase their fiber to prevent constipation. So we see how we're putting all this together just to answer a question about hydromorphine. You see how they make you put it all together. Now on to our urinary. So would you want to assess the bladder frequently? We can. And do you want to prompt the client to void every 4 hours? Yes, we can as well. Would you perform a straight catheterization every 4 hours? No, we won't. So after we assess the bladder frequently, why? As we mentioned earlier, that it can cause urinary retention, we're going to assess their bladder, and we want to prompt them, hey, to go to the bathroom. We want to start bladder training, right? Getting them on the schedule. Hey, go to the bathroom every 4 hours to try to empty out your bladder. Now, if the patient, after we assess the patient and we saw that they were retaining urine and they weren't able to go when they tried to go, then we will cap. But we're not going to say we're going to automatically perform a straight catheterization every 4 hours. We're not going to do that. All right, so this is the answers for this problem. So do you see how they make you think and put it all together? Where you might have said hydromorphine, oh my God, I only know respiratory depression from that. I only know that this is a pain medication. You see how they took all the body systems and made it relevant to this medication? So that is a wrap. I know that this was an intense 20 minutes, but I'm just letting you guys know practice makes perfect. And I will be posting more videos like this. If you need more help with these questions, my information is below. You can send me an email to either one of those email addresses. That phone number you can call or just text me. Make sure you're following the Facebook group and us on TikTok. In the Facebook group, it's very helpful. It is a private group. I answer questions there. We have daily NCLEX questions, studying tips, test taking tips, and all that kind of stuff is used in that group. If this video was helpful for you, share it with your nursing colleagues so that you're able to just learn together. It comes by practicing over and over and over. You get better at answering questions by doing them over and over and over. Well, you guys, it has been a pleasure teaching you guys today, and I will see you guys in the next lesson. Have a great day.